right, thanks everybody. Thanks for joining again. This is the last session of the 2025 series of our Australian neonatal webinars. As you've seen and logged on, there is now a group on the WhatsApp. The email sort of notifications are going to change, and we now have it's not complete yet, but a YouTube site with all the talks sort of nicely organized for you to review. Today, it is my great honor to introduce Smits. She's a neonatologist from the University of Leuven in Belgium, and we just had a little chat, a lot of neonatal pharmacokinetics is driven by Belgian physicians and neonatologists. So they must sort of, tell each other, this is just a great field. We need to know something more. And I've been reading about Anne's work, particularly in medications in different scenarios in babies with different metabolism. And that's my sort of request for her to talk about, pharmacokinetics in neonates and specifically in different scenarios, including sort of hypothermia. So Anna, over to you.
Thank you for the invitation. I will try to share my slides. Can you see the screen?
No, not yet.
Not yet. No. Then I will go out again. Did you make me presenter?
Yeah, you're a co-host, so she should be able to share your screen. Yes, starting up. Here we go.
Okay, so now you should see it in presenter mode, I think.
Yeah, perfect. Thank you.
Okay, so once again, thank you for the invitation. And the title of my talk was Farmacotherapy in Newborns, Does One Dose Really Fits All? And in fact, in neonatology, these are the three main leading causes of neonatal death, so prematurity, infection, and asphyxia. And these causes have not changed in the last decades, let's say. This means that these conditions are occurring quite often in different parts of the world, and we also need to be aware how to treat these patients in order to improve their condition and to reduce mortality. And if you have a look to the trends in drug use, in this case in extremely low birth weight infants, then you can see here the top 10 of the most frequently used drugs. You can see antibiotics, you can see furosemide, dopamine, some analgesics like fentanyl, indomethacin, and so on. And also this list has not changed over the last decades, but this also means that these drugs will be the ones, or the drug classes will be the ones that we will use within the next 10 years. So important to understand their way of working, their side effects, and their mechanism. In addition, if you have a look to the top 50 of drugs which are used very frequently in extreme low birth weight neonates, then we know that in the period of 2005 to 2010, 35% of these drugs were FDA approved. And when this exercise was done again in 2010 to 2018, 40% of these drugs were FDA approved. So there is a slight increase, but not a lot. This means that the off-label use of drugs is very extensive, especially in extreme low birth weight neonates. And we can say that about more than 90% of those very small infants are exposed to off-label drugs. This means that the drug is used in a dose or an indication or an administration route which is not approved for this population. However, off-label drug use does not mean that it's not evidence-based, because a lot of academic research has been performed in order to understand how drugs work and how we have to dose them in neonates. Based on an analysis of the Dutch medication formulary, the off-label pediatric pharmacotherapy is supported in 14% of the cases by high-quality evidence. So most of them is not supported by very high-quality evidence. And the authorized records of high-quality evidence increase also with age. So there is still a lot of work to do in neonatal pharmacology and drug use. If we specifically look to neonates, we know that there is a large variability in the drug dosing that is used across units and across countries. And this is in part related to the fact that neonates are characterized by an extensive growth and development in the population, that initial dosing is very often based on expert opinion and rather small studies, so that there is a need for high quality data on drug safety and drug efficacy. Besides initial studies, we also need validation of drug dosing regimens that occur based on PK studies. And the big black box is, of course, the pharmacodynamics, so the drug effects and side effects, because we do not understand them very well in neonates. And if new dosing information has been developed, it's also important to implement it and to disseminate it towards the different units. So overall, neonatal clinical pharmacology is characterized by pharmacokinetics. So this means the concentration-time relation of a drug, and pharmacodynamics, which is the concentration-effect relation of a drug. And these two concepts apply not only to neonates, but also to older children and to adults. So it's in fact the same. The only difference is that there's a large impact of maturation, so growth and development in the neonatal population, but also by non-maturational covariates like disease conditions, co-treatment, genetics, and so on. So all these factors impact pharmacokinetics and pharmacodynamics in neonates. Pharmacokinetics itself, in this concept, we distinguish the absorption of a drug into the blood compartment. Subsequently, it will be distributed towards different parts of the body. Then the liver is involved in most of the drug metabolism, and then drugs are excreted from the body mainly by the renal part, so by the kidneys. And in each of these steps, differences in physiology will drive the pharmacology in neonates. So absorption is altered because, for example, gastric emptying is different compared to adults, pH can be different in adults, and so on. Distribution is different because of protein binding and body composition changes. Then most importantly, immaturity of the liver and immaturity of the kidneys, which will impact metabolism and excretion of drugs in neonates. As an example for distribution, we know that a lot of drugs bind to human serum albumin. And albumin concentrations within the neonatal period change. And this is a study that we did in Leuven based on a large cohort of neonates with more than 5,000 observations on human serum albumin to derive a kind of real-world data collection to see what is a normal trend within the neonatal population. And then you can see that covariates determining the albumin concentration within a specific neonate depends on maturational covariates like gestational age, what you can see here, and the birth rate. And in addition, non-maturational covariates like sepsis or the need for mechanical ventilation also determine albumin concentration. And of course, mechanical ventilation is a kind of indication of disease severity, which results in this difference. So this is important to understand drug disposition because it will impact how much a drug can be bind to albumin, and it will also determine the free fraction, so the not albumin bind drug, and this is the only fraction which can have a pharmacological effect. And this is different compared to adult populations. However, at present we do not take into account albumin into dosing regimens, but this needs to be done within new techniques that are coming around. What about drug metabolism? We know that different isoenzymes in our liver and also in the small intestines are important to metabolize drugs and to turn it into metabolites to make it less active. And each of these isoenzymes have their own ontogeny pattern. This means that the activity will increase throughout life, and each of these enzymes has a different pattern or age at which the adult activity is reached. Here you can see two examples. So for CYP1A2 and for CYP2A6. And here you can see the example for CYP3A4. And 3A4 is one of the most important enzymes that we need to break down drugs, because it will cover more than 50% of the metabolization of drugs in our body. So it's a very important one. And what you can see in the neonatal age is that the activity of CYP3A4 is very low. So it needs some time to mature and to reach the adult activity. So just to illustrate that growth and development is important in the way our physiology changes, and consequently also how pharmacokinetics will change. As an illustration, you can see here an example of the Dutch colleagues on the maturation of fentanyl clearance in neonates. So you can see two graphs. Here you can see the clearance of fentanyl expressed in liter per hour. And here you can see the clearance of fentanyl expressed in liter per hour per kilogram. In the x-axis, you can see an increasing postnatal age, and the different colors indicate different birth rate categories, with the smallest neonates indicated in blue and the biggest ones indicated in yellow. And based on this analysis, it was a population PK analysis, it became clear that the fentanyl clearance shows a very fast maturation in the first weeks of life. And this is driven not only by postnatal age, but also by birth weight. As you can see here, you end up with very different clearances for the different birth weight categories. This also means that we do not need to dose all these cohorts the same, but that age-appropriate dosing is needed. So, and this was also done in this paper. They developed a dosing guidance for the different birth weight categories in order to obtain the same exposure within those children. This fast increase in clearance of fentanyl in early life is in part driven by the increase in CYP3A4 activity, so the enzyme which is the most important for drug metabolism. However, CYP3A4 increase cannot be the only explanation, because its activity is still low in neonatal age. So it will probably also be related to CYP3A7, another enzyme which has a higher activity in neonates and then decrease a bit when it goes to older age. So this, in fact, can explain a bit why each neonate has a different clearance and why we sometimes need to adapt the dosing based on postnatal age, but also based on birth weight. I think it's a nice illustration because the birth weight explains the prenatal maturation and the postnatal age is an indicator of the postnatal maturation. So this was an example on direct metabolism. What about the renal function? We also know that renal function matures with age. Here you can see normal values of serum creatinine for neonates in different gestational age categories for an increasing postnatal age. The smallest ones are indicated in red. So you can see that the increase in serum creatinine, which you can see in each neonate, but that this increase occurs a bit later in the smallest neonates, and that the top level is also the highest in the most immature neonates. In case of a normal kidney function, serum creatinine needs to decrease after 1 week of life and then slightly continue to decrease further on. The same can be seen for glomerular filtration rate, which increases with age and is again the smallest in the most immature neonates. So this is important to understand how we have to treat our children, because this physiology is also reflected in the dosing regimens. Here you can see the amikacin dosing regimen that we currently use and which is based on a population PK analysis. So based on the current weight and the postnatal age, so the most important drivers of both the clearance and the volume of distribution, we developed different dosing categories. And you can see that for the most immature neonate, the highest dose expressed in milligram per kilogram has to be administered because they have the highest body water compartment. And in order to have an optimal efficacy of amikacin, you need a good P concentration. The second thing that you can see is that for the most immature neonates, we need the highest dosing interval. And this is because their kidneys do not work optimally. So you need a long period between two doses in order to be able to clear the drug from the body. And in this way, you can see that physiology is in fact reflected in this dosing regimen. These principles do not only apply to amikacin, but also to other aminoglycosides. For example, if you use in your unit gentamicin, the same physiological approaches will determine your dosing regimen. As another example, here you can see how the administration of antibiotic drugs like amikacin, but also vancomycin, can alter the renal function in very low birth weight neonates. Again, here you can see the profile of serum creatinine as a function of postnatal age. You can see again an increase with the highest increase for the smallest neonates. And if you then add antibiotics to it, you can see that the serum creatinine increases again. And this increase is the highest when you express it in percentage. It is the highest in the smallest neonates compared to the bigger ones. Also for creatinine clearance, the impact is the highest when you administer those drugs in the smallest neonates, because their renal function is the most immature, so they have a higher impact of it. So also there we need to take this into account into our dosing regimens, and not only our preterm neonates mature, but also the dosing regimens that we use have to mature and have to evolve with our patients. Now, how can we develop these dosing regimens? How can we learn more on the physiology and consequently the pharmacokinetics? There are different modeling approaches that can be used to improve dosing regimens. The most well-known is population PK analysis. And in this approach, you try to explain what is the general trend of the concentration time profile, so the pharmacokinetic profile in your population. So what is the general trend line? And in the second step, you try to explain why an individual observation deviates from this trend line. Is this because it is a smaller child? Is this because it has a different weight, or it has a different disease condition? So why does this differs from the general trend line? And when you understand these covariates, you can use them into dosing regimens. A second approach is a physiology-based PK model. This is a kind of computer model where we combine characteristics of the drug with characteristics of the population of interest, and we try to build a kind of virtual population using the physiology of this target population. For example, the neonatal kidney, the neonatal liver, and so on. And then we try to predict how a specific drug will behave and what an optimal dosing regimen will be in order to end up with a good exposure, not too low and not too high. And of course, the final aim is to develop a kind of integrated pharmacokinetic pharmacodynamic models in which we not only integrate how the drug will, their concentration will behave, but also which effect and side effects we can anticipate. And in this way, we try to go from a one dose fits all towards a more appropriate dosing for each individual neonate. For example, in case of extreme low birth weight neonates or hypothermia neonates, how can we dose them differently, and how can we end up with an optimal exposure for each neonate? So this was a bit the background information. If we then specifically go to the setting of perinatal asphyxia, so one of the 3 conditions which has a great a large mortality within the neonatal population, then we know that about 5 in 1,000 live-born babies display perinatal asphyxia. Of course, this incidence is higher in low and middle-income countries compared to the high-income countries. And therapeutic hypothermia has been introduced from about 2010. And after this introduction, we see that adverse outcomes like death or severe disability, they decrease from about 45% towards 29%, and mortality has been reduced from 25 to 10%. So this is already a very effective therapy. However, up to 29% of the neonates with hypoxic ischemic encephalopathy, which are treated with therapeutic hypothermia, still develop adverse outcomes despite this cooling treatment. So there is some room for improvement, and maybe this can be done by optimizing our pharmacotherapy. Just as a small repetition, what do we know on the pathophysiology of asphyxia? So when the placental blood flow is compromised, the fetus will redistribute its cardiac output towards the most vital organs. This means the brains, the heart, and the adrenal glands. But this also means that other parts of the body will receive less blood, for example, the kidneys, the lungs, the intestines, and so on. And this is also what we see in the clinical setting, as well as in the lab values of these babies. They have an increase in liver values, they have a decrease in renal output. So this really has a specific impact. If the asphyxia is ongoing, then we will also see a decrease in myocardial blood flow and cerebral blood flow, which can result in ischemic cerebral injury. And of course, as you know, this will release a lot of oxidative stress, excitotoxicity, and cell death, not only in the immediate setting, but also few hours and days later, it will continue and result in hypoxic ischemic encephalopathy. So a lot of these babies need intensive care setting, need supportive therapy, for example, anabolic sedatives, antiepileptics, inotropics, and antibiotics. But also a lot of therapy or research has been done to add additional drugs in order to improve the neurological outcome of these babies. So pharmacotherapy that can be used as add-on to improve the outcome, add-on therapy to cooling. And for all these drugs, both this add-on pharmacotherapy, but also the supportive pharmacotherapy, we need to understand how we have to dose them, or how cooling as well as asphyxia can impact the disposition and the pharmacokinetics. First, what do we know about the impact of cooling and asphyxia on renal drug clearance? Here you can see amikacin clearance in the y-axis, and you can see birth weight in the x-axis. What we know from what I have already told you on amikacin is that the clearance increases with weight, but also with postnatal age. And so these graphs are the babies in our NICUs without asphyxia, without cooling. If we then have a look to amikacin clearance in the case of asphyxia and cooling, we see that there is a decrease of about more than 40%. So this means that we need to adapt our dosing regimen due to this significant decrease in clearance. Based on the population PK analysis, we indeed refined our dosing regimen, and increasing the dosing interval with about 10 to 12 hours results in optimal exposure and less toxicity compared to the normal dosing regimen. So the number of trough levels significantly decreased, and the trough level indicates in this way the toxicity. This is not only something which has been seen for amikacin, but also for other drugs using the same elimination route. For example, the other aminoglycosides like gentamicin, also their decrease in clearance has been seen of about 30% in asphyxia treated with hypothermia. So in order to reach optimal exposure, you need to increase the dosing interval of these drugs. We also highly recommend to use therapeutic drug monitoring for drugs with a very small therapeutic window, for example, amikacin, gentamicin, vancomycin, because this will significantly help you to obtain a safe exposure for this specific population. Because we know that we have to increase the interval, but then each baby reacts a bit different. So in this way, TDM still remains very important in this specific setting. Of course, it's not so easy to distinguish the impact of hypothermia compared to asphyxia in neonates. And at this point, it's also not ethical to do not offer cooling anymore to babies. So to do research on this part, we also need animal studies, and I will explain more later on, to distinguish the impact of hypothermia versus asphyxia. Because these animal studies, as well as in vitro research, can support us in understand the different impact of both events. Here you can see an example of another antibiotic drug, which is ceftazidime, a third-generation cephalosporin, which is commonly used, for example, in pseudomonas infections or other gram-negative infections. And we know that the clinical outcome of ceftazidime is related to the time that the unbound concentration remains above the minimal inhibitory concentration, so indicated with the MIC value. And in case of a very severe infection, even thresholds of 4 to 5 times the mix are indicated as a threshold. Here you can see the concentration of ceftazidime for increasing postnatal age, during hypothermia, during rewarming, and during normothermia. And you can see that during normothermia, concentrations decrease below the threshold values, and this is in part related to the fact that the baby gets older, so the postnatal age increases, but also due to the fact that kidneys work better during the normothermia period again. This has been confirmed also in population PK analysis. Very recently, also vancomycin clearance was investigated in asphyxiated neonates treated with hypothermia in a multicenter prospective study, where they also developed a population PK model to understand which are the main drivers, which are the main covariates of vancomycin disposition, and frequently used dosing guidelines like from the Dutch Foundry were evaluated to see if they could reach the target that is needed. Overall, the authors concluded that there is a reduction in the vancomycin clearance in the specific patient population. And this can result in overexposure if you just use the normal guidelines for dosing regimens. So you need to adapt it in order to end up with a safe exposure. So this was the renal part, so drugs eliminated by the kidneys. What do we know about drug metabolism during hypothermia treatment? Here you can see two graphs indicating the clearance of morphine, a frequently used analgesic, with increasing time after birth. And in this panel, you can see the clearance values for babies with varying gestational age, but with the same birth rate. And in this panel, you can see the clearance values for neonates with the same gestational age, but with different birth rates. In this part, you can see the clearance values during hypothermia, followed by the clearance in normothermia. And you can see that there is a significant decrease during the hypothermia period. And this has been confirmed by many studies indicating that their concentrations in the blood are much higher during the hypothermia phase. This means the neonates cannot metabolize the drugs very well because the metabolism is lower during this hypothermia. And this is thought to be a combination of the asphyxia as well as the hypothermia having an impact on the liver. This means also that babies can become more sedated or more sleepy, and that you need to titrate the concentration. So you need to decrease the dose, especially from the second day onwards, in order not to end up with a very sedated baby. This is for morphine, but also for fentanyl and other drugs which undergo drug metabolism. It has been indicated that the concentrations are higher because the baby cannot metabolize the drug optimally, and the effect will remain longer. Of course, our changes in care practices during hypothermia are illustrated here. So from the start of the cooling therapy in 2010, most babies received mechanical ventilation, were fully sedated, high doses of opioids were used. And if we have a look now, not each baby is intubated anymore. So also non-invasive ventilation is used. This also means we have to adapt our pharmacotherapy. The baby can be awake but needs to be comfortable. So we need lower doses of opioids, but this can be accompanied by new drugs, for example, dexmedetomidine or other alpha-2 agonists, which can provide comfort but less suppression of the central nervous system. And of course, more family-centered care and care bundles are integrated into the care nowadays, which also makes the setting different. And this has also impact on how we use drugs in this setting. Another nice example on drug metabolism can be seen for phenobarbital and midazolam. So two drugs which are also used in neonates with asphyxia treated with cooling. They can be used for sedation, but also for epilepsy. And we know that midazolam is a drug which is metabolized by CYP3A4. So the enzyme, which is very important because it metabolizes more than 50% of the drugs. On the other hand, we know that phenobarbital is an inducer of CYP3A4. So it makes the enzyme work faster in case phenobarbital is administered. This also means that when you combine both drugs in a patient, that you have to be aware of drug-drug interactions. So the co-treatment of both will result in an increase of midazolam clearance of more than twofold. This means the drug is eliminated faster from the baby and the effect will be less. So you have to be aware that this can happen, that this can occur, and this can explain you why specific babies do not react like you anticipated. Besides maturation, I already explained that non-maturational factors can impact pharmacokinetics and pharmacodynamics in neonates, and therapeutic hypothermia is one of these examples. It's a treatment which impacts the metabolism and the clearance of drugs. But there are also other situations in which we can see an impact, for example, critical illness, severe inflammation, other artificial support devices, think about ECMO or dialysis, pharmacogenetics, and also extreme low birth weight are conditions impacting PK of drugs. And for these conditions, sometimes altered dosing regimens are developed. If I can then go to a part of our work that we do on asphyxia and hypothermia. So what we have been doing the last years is trying to develop a physiology-driven pharmacokinetic framework for asphyxia and hypothermia to understand how these conditions impact the drug disposition. It's a kind of computer model where we start from the adult setting. So what do we know about specific drugs and what do we know about the physiology of the human body in adults? Then we scale down to children. So we add to the computer all the changes in physiology that we see in children compared to adults. Then we scale down to neonates, and then we scale down to specific disease setting like asphyxia and hypothermia. And then we implement all the changes in the physiology, for example, the decrease in clearance of the kidney, the decrease in clearance of the metabolism, in order to predict how a specific drug will behave. As I already explained, for this type of research, we cannot randomize children receiving cooling or not. So we need to go to in vitro research as well as animal research to feed the computer model and to understand how the physiology changes. So we use in vitro data on drug enzymes, and we use data of the mini-pig. The Göttingen mini-pig is the most important pig strain for drug development, so that's why we use these animals. We combine it into the computer model and then also add information of the human setting and human neonates in order to develop the pharmacokinetic model. Here you can see some results of the clearance of a few compounds that we selected in the mini-pig. You can see the clearance of midazolam, of fentanyl, the concentrations that we see in those piglets for midazolam and fentanyl. And we distinguished four conditions, a control setting, hypothermia or hypoxia. This is hypoxia, this is hypothermia, and this is a combination of both settings, so the hypoxia and the hypothermia. There was a decrease in clearance in the hypothermia setting for midazolam and fentanyl, which is a bit in line with the human setting, where we also see a decrease in midazolam and fentanyl clearance. So in this way, we can feed our model to better understand how the drugs behave. Of course, if we need to investigate or do studies for each individual drug, this will take us many years because asphyxia and hypothermia is a quite rare condition. We have a few cases a year, but not like 100 cases. So in order to move forward, we are looking for biomarkers that can help us to say something about the impact on drug metabolism in this population without the need to study each drug separately. And one of these biomarkers is 4-beta-hydroxycholesterol divided by cholesterol. This ratio can tell us something on how good CYP3A4 works, because CYP3A4 in our body is needed to develop or to make this biomarker. So it's in fact an endogenous substance, an endogenous marker that we can use to say something on CYP3A4 activity. However, the data on this biomarker are quite low, are quite limited, so we don't have a lot of data, but it can be something in the future that we will further explore to see if it can learn us how to dose drugs that are metabolized by CYP3A4. So in our unit, we collected samples in neonates with asphyxia treated with hypothermia. And we compared these with surgical controls, so neonates without asphyxia, but also with critical illness, needing a NICU admission. And we see that there is an increase in this marker with postnatal age. So this nicely illustrates or supports the ontogeny, the increase of the activity in CYP3A4. And more at the end, there was a slight difference between the cooled and the non-cooled cases. But this, of course, needs further exploration to see if we can use this. If we try to make this kind of pharmacokinetic models, especially the physiology-driven models, then we need to optimally understand how the physiology is different compared to a normal neonate. This means we need normal values of the kidney function, we need normal values of albumin data, and so on. This is also what we have done with some master students to collect data on these different organ systems in the population of neonates needing cooling therapy, because this will significantly improve our models and improve the prediction on how a drug will behave. Here you can see the results of Zoe van der Elst, one of our PhD students, who performed a retrospective multicenter study on albumin values in asphyxiated neonates. So a few hundred cases were included. And here you can see how the albumin trend changes over time with increasing postnatal age for neonates with asphyxia treated with cooling and control population. And you can see that the median value differs significantly between both cohorts, and also the disease severity will impact how albumin trends change over time. We then compared the function that we developed to explain albumin values over time with the albumin value that can be found in software for a physiology-driven pharmacokinetics. And this software is called SimSip. And if we then compare our function that we developed with the function in SimSip, we see that there's a large difference. Yeah? And this is important to understand because this means that in the available software nowadays, the normal trends of albumin for asphyxia babies are not covered. It are mainly the albumin trends of the healthier neonates. So this is not optimal to derive dosing regimens for drugs which are bound to albumin. So this is just to illustrate that there is still a lot of work to do to understand the physiology and to improve this type of modeling efforts. Of course, where can you find currently available dosing information? There are a few papers. For example, this review of Lutz et al. Of a few years ago nicely describes the pharmacokinetics in neonates with cooling and also provides some dosing recommendations. And also the Dutch pediatric formulary, which is currently also available in some other countries, provides cooling information for some specific drugs. So I think knowledge is increasing. We understand better how the kidneys are impacted, how the liver is impacted, and how this will influence our treatment. Not only the supportive drugs need optimal dosing, but also for the add-on pharmacotherapy that is under investigation to improve the outcome of neonates with asphyxia treated with hypothermia. These kind of pharmacokinetic models are important. At this moment, there are a few studies ongoing for example, with melatonin, to see if this can be helpful to give this in addition to cooling to improve babies. But also sildenafil and other compounds are under investigation, and this kind of PBPK models can be helpful also for these studies. I'm coming to the end of my presentation, and I would like to conclude that there is a complex interplay in covariates, both maturational as well as non-maturational covariates, determining the drug disposition in neonates. If we specifically have a look to neonates with asphyxia treated with hypothermia, we know that there is a decrease in the clearance, both the renal clearance as well as the metabolic clearance. Of course, how we treat these patients nowadays is different compared to some years ago, where we try to make the babies more awake but comfortable. How can we support optimal dosing strategies? This can be done by pharmacokinetic modeling. However, we need to understand the physiology optimal. So there is also a request to clinicians to help us to collect data on physiology, because this can improve the modeling. And of course, to keep it safe on the bedside, please use therapeutic drug monitoring for drugs with a very small therapeutic window. Also, closely follow up your clinical setting. If a baby is too sedated, then you have to be aware that you need to decrease morphine, fentanyl, or other sedatives. Maybe use neuromonitoring to see how deep a baby is sedated, because it can also help you in the guidance of the dosing and to understand how the baby behaves. So I would like to thank you for listening, and if there are questions, I'm happy to answer them.
Well, thank you. This was a wonderful overview of pharmacokinetics, predominantly in newborns, where you could just sense through it. Beautiful slides. You described the development of physiology and what that means to drugs in newborns. You went to the distribution, and that data I thought was wonderful about just albumin and how it changes with gestational age, sepsis, even mechanical ventilation. I thought that was just very interesting. And then, about the liver function and the kidney function onto it. And then you made the statement, mature your dosing. And we will get back to that, because that will definitely be a question here. You showed some very elegant data to make sort of concepts and deal with this, and particularly then a lot of elaboration in the work in hypothermia, which you and your group did. The clearance changes, they were fantastic. The birth rate and the gestation, even that small little group, only 4 weeks or 2,000 grams difference in that group already made a major change, I thought, in the clearance sort of maturation of it. These are complex interactions which you explained, for instance, with the difference between phenobarb and midazolam, and then you showed us some really, really elegant animal data to unravel this complexity of this pharmacokinetics in newborns. And I'm excited, which you are probably as well, as these biomarkers for enzyme activity, which would be great. I'm going to start off, well, maybe people have some questions, they can put their hands up. I'm going to go into that maturing our dosing. I think it's, what you showed us is, yes, we absolutely need to mature our dosing. How are we going to do this? This is so complex.
Yes, I think, as I explained, so these population pharmacokinetics and physiology-driven pharmacokinetics, they are a kind of statistical computer models, and it can say us which of the covariates are most important. Is it the weight? Is it the age? Is it the disease? And when we can define them, we can use it into our dosing regimen. So this is why, for example, in amikacin, we use the weight and the age, but we also know that when you give ibuprofen in addition to it, you need to also increase the dosing interval. So based on this, we make dosing safer. We make dosing regimens more complex because we have more dosing categories. It's not just one dose, but we have 10 different dosing categories. So it makes it more complex to use in the clinical setting. And there, I think it's important that that electronic prescriptions can be helpful, because then you can preset the dosing in your electronic healthcare system to avoid mistakes in calculation while still using these more complex regimens, because in the past it was easier to add just one dose fits all, but now we have different categories, makes it more complex, more easy to make mistakes. But I think electronics can help us there, and the computer systems that we use now.
You see like a future with, your software or AI, you type in all these things, including what the AEG looks like, including how sedated the baby is, including creatinine and albumin, and then it says it recommends these doses for you. Do you see a future like this?
Yes, and I think it's already happening. I think the colleagues in Rotterdam, they have a pain dashboard in which they indeed try to integrate all the available information. And the ultimate goal would, of course, be that you also integrate the PK models behind it, so that the computer can suggest you how to dose. And another example is, I think, model-informed precision dosing, MIPD, which is also a kind of computer software which uses all the information of your baby, the weight of today, the kidney function of today, the other drugs that you are administering, and make a dosing suggestion. So this is really coming into practice. The difficult thing is the medical device regulation at present, which makes it not easy to implement new software because it asks a lot of administration and regulation. But it exists, and I think in the next 10 years it will become more and more used within our clinical practice. I think it's good because it makes the care better, it makes the treatment safer, more adapted to each individual. But it also comes with some challenges on how to implement, on how to learn it to the nurses, to the doctors, and so on.
Yeah, no, the complexity. But look, I agree with the electronic patient data files and then added on software, which I think what will happen first is suggest, not automatically order it. That will be a step too far for now. But I'm really looking forward to that. You did this wonderful study looking at all just reference values, and sometimes I'm amazed how few reference values we have for different populations of different laboratory values. And the one on albumin I thought was striking. Why was albumin so much lower in mechanically ventilated babies?
Yes, we think that it's an expression of disease severity, because when is a baby ventilated, for example, when it has a severe sepsis or when it comes back after surgery, and in these two conditions it has been described that you have more edema, that you have lower albumin production, that you have leakage of albumin. So in these conditions, it's really the disease severity which explains those low values. But indeed, if you then give a drug which is highly bound to albumin, and you have less binding places, it results in more pharmacological effects. So in fact, we need to use this information in our dosing regimens. However, we do not really do it at this moment. But I think that will also be the next step in physiology-driven PK, that we use these reference values of albumin, of kidney function, of liver function, and so on, to mimic the physiology of this population better.
Yeah.
And I think, just to be aware, I think we did it on albumin, but the International Neonatal Consortium very recently launched a kind of web-based platform where you can see reference values of other lab parameters, for example, the liver function, lactate, creatinine, a lot of lab values, so that you can see, depending on gestational age, what the normal value would be for your baby, to use it bedside and to see if your baby behaves the same as what you expect or not.
It can be very helpful for all sorts of reasons, including sort of drug dosing. Now, you talked quite a lot about pharmacodynamics. Pharmacokinetics. It was pharmacokinetics. And you only hinted on pharmacokinetics. I'm a clinician, you're a clinician, and sometimes we give a baby a drug. And for instance, if we take a very simple drug, anything that increases blood pressure, the time it takes for that baby to increase his blood pressure is hugely variable. There are technical issues, I understand, but how much of that is pharmacokinetics?
That's a good question. I think pharmacokinetics can help us to understand disposition, but then you need to know what is a normal concentration of a drug in the blood. If you talk about blood pressure and inotropics, it's more pharmacodynamics, of course. You want to see the effect, and there we do not know a lot of pharmacodynamic normal values. What is a normal blood pressure? What is hypotension? And that's the big black box, as I said, the pharmacodynamics, because for many parameters we do not have these normal values. And also how receptors function in a body, where your inotropics will work on, the ontogeny of these receptors. These mechanisms are not very well known in babies. And this is also in pharmacology a real challenge on how you would study this, because there's a lot of variability within the population. And also there, I think more in vitro research and animal research can help us. But I have to admit that this is really, really challenging, that pharmacodynamics is something we not really understand yet.
Yeah. Because I know your group works on sedatives quite a bit and found this huge variation of how sedated a baby could be with exactly the same dose. And I was just wondering, did they also have the same pharmacokinetic sort of, layout and physiology? Or is it indeed something which it's just almost like a black box and it's hard to study?
It's hard to study, but there I think new tools like the neuromonitoring, in our unit we use it very often, it can be tools that inform us better on pharmacodynamics. For example, we did a study on propofol, a dose finding study in neonates receiving propofol for an intubation. We combined this with NIRS vital signs and EEG. And then you can see that the hypotension takes more than 2 hours, that there is a decrease in cerebral activity, a decrease in cerebral oxygenation. And then you can disentangle how the dose relates to these effects. So I think these kind of tools, especially for sedatives, but also for antiepileptics, can be very helpful to combine it with pharmacokinetics and to learn more of the dose and how we have to adapt the dose for different settings. So I think this will be the future, that we integrate these tools more in our research as well as clinical care.
Yeah. Look, any questions?
Yeah,
I still think there's no questions from the group. This has always been a challenging topic, I know that. Look, Anne, thank you so much for getting up this early and talking for us. It was a wonderful presentation. There will be a recording. I will send you the link sort of thereafter, free to share. Thank you, everybody, for attending again, and we will be back in February starting with our program again. So thanks again, Anne. Have a good day.
Thank you very much. Bye-bye.
Dankjewel. Groetjes.